Good morning, everybody. I hope everybody having a wonderful start of the week. I'm very glad and actually excited to have our grand round speaker this morning. Dr. Mark Henderson came to my attention a few years ago when he was reading an article about his, I would say, pioneer approach to really have a different uptake of how we can really increase our workforce with more diverse medical students, particular at the climate that we are facing these days. With further ado, I would like to introduce our speaker, that is a professor of the internal medicine and associate dean for admissions at University of California, Davis. Of the School of Medicine, Dr. Henderson is the community of practice lead for the UC Davis HRSA-funded National Center for Diverse Healthcare Workforce, and is an expert in reforming medical school admissions practice to enhance racial and ethnic and economic diversity. And he will be talking more about it in his talk about the adversity scores. It's a very cutting-edge approach. Over the past 17 years, he has led the UC Davis efforts to become of most diverse medical schools in the U.S. He's a co-principal investigator of Accelerated Competency-Based Education in Primary Care, also known as an ACE-PC program. It's a 3-year medical school track for students committed to primary care, and the California-Oregon Medical Partnership to Address Disparity in Rural Education and Health, Compadre, both funded by American Medical Association. Compadre is a cross-strait partnership between UC Davis and OHSU that aims to transform the physician workforce by admitting and training students for rural and tribal communities for future practitioners and this underserved community. Dr. Henderson holds the Dean Endowed Chair in Teaching and Excellence and teach a UC Davis Study Abroad course in Spain. Well, Dr. Henderson, I'm so excited to have you here. I mean, this is going to be a wonderful start of our week, and thank you so much for come and share your knowledge with us.
Thanks for the opportunity, Catherine. Let's see, I'll share my slides here. And good morning to everyone. Let's see. Let me know if I think they're there.
They look great.
Yeah, we can see them.
Okay, perfect. Thanks. So yeah, as Catherine mentioned, I'm going to be speaking about, the title of my talk today is Cultivating the Physicians Our Nation Needs After Affirmative Action Has Ended. So these are a few of our students. The three there has to do with a few years ago, the school was rated as the third most diverse school in the United States, behind the historically Black colleges and universities. And I'm going to talk a little bit about how we achieved that, and it didn't happen overnight. So there are a lot of things that went into that, which I'll talk about. I don't have any disclosures relevant to this topic. These are my learning objectives. The first is to talk about social accountability as a driving force for medical education, and particularly about how increasing representation relates to health equity. Second, I'll talk about the composition of the physician workforce, including obstetrics and gynecology in this country and state. And then finally, we'll talk about the method, the holistic admissions method that we've used for about 25 years here at UC Davis after affirmative action was banned in our state in 1997. The first to start off, I think, was the organizing principle of why we do this work, and it has to do with health equity. This is the Center for Disease Control and Prevention framework on health equity, which is defined as when everyone has the opportunity to be as healthy as possible. Now, I think I like this picture because there are lots of different pathways and lots of different things that need to change for this to occur, and we're not there yet. So, programs have to be developed. We have to measure our success, our progress, and then there needs to be policy change for this to occur. And finally, there needs to be a greater investment in infrastructure, particularly primary care infrastructure. This is just an example of how healthcare is not equal, and that where you live matters way too much. So this is the mortality on the right-hand side of the slide in the zip code in which I live. 87. And then the zip code in which I work, which is 18 miles away, is 77. So it's a 10-year difference in life expectancy across 18 miles. So I don't think anybody believes this is just or right. On the right-hand side of the slide, this is a pretty recent paper that looked at every county and zip code in the United States, and over a 10-year period looked at the density, this is of primary care physicians in a zip code, and related that to the mortality, the overall mortality in that zip code. You can see there's a linear relationship. The greater the density of primary care physicians in a municipality, in a region, the longer people live. They also did this analysis with specialists, and it's not the same relationship. It's more of a straight line. It's actually slightly increased. So there's also an improvement with specialists, but is not nearly as great as the improvement in community health that goes along with primary care physicians being in a community. Now, in our state, this is no surprise to any of you. Most areas of California don't have sufficient density of primary care physicians, and there are projected shortages of 10,000 by 2036 just in our state. I show this map on the left-hand side of the slide just to demonstrate that there are areas of adequate primary care physician density, but they're mostly the Bay Area, Los Angeles, and San Diego. In the middle panel there on the left-hand side of the slide, you can see all of the areas where coverage is insufficient. And it's all of the areas between, let's say, Sacramento and the Oregon border, the entire Central Valley, and then particularly dire shortages are in the Inland Empire. You can see there at the bottom right-hand side of the state, if you will. And then it just sort of thinking about access to a physician. About 30% of Americans don't have adequate access to a primary care physician, which tends to be the entry point to the healthcare system, of course. So in San Francisco, you can see there's a primary care physician for every 160 people, versus Grass Valley, near where I live, 1,100. One for 1,100. So there's a lot of geographic maldistribution of the physician workforce in our state and elsewhere. This is
Dr. Henderson, sorry, this is Dakeen. Somebody is not muted, and we can hear a lot of clunking. So could everybody please check that they are muted? Thank you very much. Sorry.
Thank you very much, Dakeen. This slide is a model about how diversity or representation improves health equity. So this is developed by the Department of Health and Human Services. It summarizes a lot of literature. But basically, on the left-hand side of the slide, you can see with greater representation in the health workforce, physicians and other providers, there's greater cultural and language concordance between those providers and the patients, in addition to being more practitioners from disadvantaged communities. That leads to, via 4 mechanisms of greater health outcomes. The first, and these are the green boxes, are better communication outcomes and a greater level of trust, which is critical for many health conditions. Secondly, there's greater likelihood that those providers go into underserved communities to serve. And then again, I mentioned, especially among marginalized groups of patients, there's greater trust where there has been a lot of mistrust over years, decades. And then finally, such individuals tend to advocate in their own healthcare systems and outside of them for access to care for disadvantaged communities. And this leads to better quality for individual patients, but also improved health outcomes and reduced health disparities. So this is again, a mechanism by which greater representation leads to improved health equity. Then this is a busy slide. It just is the empirical evidence about how racial identity in healthcare matters. So if you're from a minority population or a Medicaid or Medi-Cal patient, you're much more likely to be cared for by a non-white physician. And in the red boxes, you can see the odds ratio for a Black patient, 23 times more likely to be cared for by a Black physician. If you're a Latino patient, you're 20 times as likely to be cared for by a Latino physician, et cetera, et cetera. So in disadvantaged communities, immigrant communities, minoritized patients tend to get their care. It's much more likely to come from physicians from those communities. Now, this hopefully isn't news to you. This is the demographics of the United States. On the left-hand side of the slide, you can see that 60% of Americans are white, about 20% are Latino, or 1 in 5, and about 13% are African American. 6% are Asian. That's the left-hand side of the slide, and about 1% Native American. On the right-hand side of the slide, these are physicians in this country. You can see, I'll just highlight a couple things. There's a lot of mismatches. The biggest one, the most acute, sort of most obvious one is the difference between Hispanic or Latino physicians. That's 7% of doctors in this country. It's also 7% of doctors in California, compared to, again, in our state, 40% of the population is Latino or Hispanic. So 7% versus 40. The other kind of striking difference really is the Asian subgroup of physicians is overrepresented. So 21% of physicians versus 6% of Americans, if you will. There's a disparity between the Black physicians and Black community as well. And of course, with the American Indian Alaska Native community, there's also a big mismatch. Now, what about obstetrics and gynecology? I put some numbers up here. In practice, 66% of OBGYN physicians are white. Again, I highlighted 9% are Latino. Again, that's compared to 40% of the California population. 11% are Black, 9% are Asian. And residents in OBGYN, similar, although there's a greater number of Asian subpopulations or individuals identified as Asian in the residencies across the country in OBGYN, 17%. And then again, the Latino representation is low, but it's not zero, but it's lower compared to our population or the US population. I put Medi-Cal patients here because I think in OBGYN, there are many patients who get care, obstetrical care, have Medi-Cal. So you can see over 50% of Medi-Cal enrollees are Latino. If you sum up all Medi-Cal enrollees, almost 60% are from underrepresented in medicine groups, the patients. So here you have very much a disconnect or a mismatch between the patient's identity and the workforce. I put a couple other statistics there. These are applicants to OBGYN and their match rates. The match rate for Latino applicants is lower than for the other identities. So that might be why, maybe, or one of the reasons why there's lower, if you will, representation in residency. And then about 20% of people who match in OBGYN have a physician parent, and about 15% are first generation college students. Now, you may be aware of this, but over the last 25 years, medical schools, ostensibly because of these problems with health disparities, have expanded dramatically. So over between 1997 and 2017, you can see that medical school enrollment rose from approximately 19,000 to almost 30,000. Now today it's almost 32,000. So that's new medical students every year, almost 32,000. So it's a rapid expansion. But over that period of time, and this is the highlighted red box, the percent of medical students from the underrepresented groups, and again, that's Black, Latino, or American Indian Alaska Native, has actually fallen by 20%. So it's gone from 15% of entering students to 13%. So while the absolute numbers, and people talk about an absolute increase in the number of underrepresented physicians, that has increased, but the representation, the proportion has fallen, quite significantly. This paper is from a couple of years ago. I think more as disturbing, perhaps, is the economic disparities that are present in medical school. So this is the family income of all U.S. medical students over the past, again, about 10 years. This slide's about 5 years old, but the data is the same today. The gray bars, the light gray and the dark gray at the top of the slide, that's the top 20th percentile of family income, or the top quintile. At the bottom of the slide, you can see the bottom quintile of income in this rust color, dark rust. So you can see there's actually 10 times more, if you will, wealthy students than there are low-income students. So it's quite dramatic. Even if you graph the average U.S. family income, average median, it's in the little green bar down at the bottom of the slide. So only about 20% of medical students in this country come from the average family from an income perspective or less. So, you could ask yourself, I mean, again, if you think about the patient population, Medi-Cal population in particular, you can see many of them are from below that green bar. Now, I like this paper. It's a couple of years old, national study that looked at your chance of being admitted to medical school. It's on the left-hand side of the slide. It is directly related to your income. So as your income goes up, you can see that straight line. The wealthier you are, the higher your chances are of getting into medical school. And actually the proportion of high income students, this paper on the right did an economic analysis. Higher income students are becoming more represented over time, more represented. And this is true amongst all racial and ethnic groups. So it doesn't matter which one, although individuals from certain Asian subpopulations, particularly Chinese and South Asian or Indian, tend to be higher income, so the highest income. Again, wealthier or people, you wonder, again, getting into medical school, is it a meritocracy or is it something else that explains this? The bottom line is that low income students are shut out of this generally, and medicine doesn't really reflect our society culturally or economically, even in California. So all of this data I just showed you is before the Supreme Court decision in June of 2023. So of course, based on actually data in our state and 7 other states that had affirmative action bans put in place over the last 20 years, representation in medical schools is going to get worse. It's going to become lower, if you will, or less representative. And so for us at UC Davis, this data, going back actually decades, was really what John Cotter would call a burning platform, which is his metaphor for change, organizational change, or call for change. Really most change efforts fail if there's not a sense of urgency. This is a burning platform in the Gulf of Mexico. So when you're on one of these, right, you have very few choices. You have to jump in the water to save yourself, or you burn in the fire. So a burning platform is a nice metaphor for, I think, what needs to happen. I think Catherine alluded to this article from last year, I guess, which was in the New York Times. I'm just going to read this. To build a diverse class of students, the medical school at UC Davis ranks applicants by the disadvantages they have faced. Could this work across America? I'll talk about what we did, and then maybe we can talk about what might apply. I think the first thing we did was we articulated what I'd call a social mission. Now, the University of California is a public institution. Its founders established it with the following mission statement: we a public university that would educate wealthy and low-income students alike, so that all Californians would benefit. I also put a quote from Lyndon Johnson here, The Great Society: poverty must not be a bar to learning, and learning must offer escape from poverty. To me, these two things are really a driving principle about how we operate. Or it's again a mission that aims to improve to social good, and that medical education, medical schools, even graduate medical education should train physicians that meet the health needs of our society or our communities. Now, to do this, I think you have to look at candidates quite differently. So, of course, everyone knows this is Brad Pitt on the right-hand side of the slide. This comes from the movie Moneyball, which was a book by Michael Lewis, which profiled the Oakland Athletics in the early 2000s and how they changed the way that they scouted for talent on their team. And it was very controversial at the time, meaning they looked at different measures. And their thinking behind this was that if the goal was to win baseball games, okay, that they actually discovered through statistical methods that an on-base percentage, I'll give you as a specific example, which was not being looked at all, was better than a batting average at predicting a team's ability to win games. So they started changing the way that they recruited. I think the same metaphor applies to medicine in the following way. If if success means meeting society's needs, we're probably looking at the wrong measures at this point. And I listed a few of those here: grade point average, MCAT, publications. There's not a lot of evidence that those measures actually improve health outcomes of society, or meet health health needs even of society. So, however, if we keep using that lens, and our thinking was we can't use the same lens, we have to change the lens if we wanted to achieve the social mission I talked about earlier. So this is our kind of our method. And again, I would label it socially accountable admissions. We have a mission statement, and that mission statement is to matriculate future physicians who will address the diverse health workforce needs of our region. And our region is California, Northern California in particular. To do this, we have very, very wide input into the process. So our interview process involves, of course, physicians, but it also involves nurses. We have a few patients. We have other people. We have students. And our thinking here is that everyone has a stake in healthcare, and everyone understands a little bit about it from their own personal experience. So we try to have as broad a representation in the entire process throughout the process. We use multiple mini interviews, which are blinded to metrics where you went to college. It's a closed file interview. The reason we do that is the interview is meant to assess interpersonal competencies and communication skills, ethical reasoning, things that are not really present in an application. We look at the application separate from that. It's not that we don't look at those things. It's just that we don't let them contaminate the interview process. We look at mission fit. What does that mean? I'll talk a little bit more about that. It's the mission that I just stated. Lived experiences of healthcare, that is particularly lived experiences of healthcare disparities, or coming from an underserved community, or having difficulty accessing healthcare personally as a patient, or in your family, or where these individuals grew up. We use need-based scholarships. We don't use, quote, merit-based scholarships. And we have a lot of partnerships with local high schools as well as local community colleges in the region, which help us to tap into, I think, very rich sources of talent. As a result of a lot of these things, on the right-hand side of this slide, there's some statistics about our school. About 45% of our students are the first in their families to graduate from college. That's the highest percentage in the United States. Nationally, about 14% of US medical students are first-generation college students. The average family income of a student at UC Davis is about $70,000. Again, that's the median family income. That's a little bit less than the median family income in the United States. 75% of our students receive financial aid, which is in the 90th percentile. The scale that Catherine mentioned, the adversity scale we use is a combined metric that uses 8 variables. I've listed a few of them up here. Family income is one of them. Parental education, which is a huge influence on educational opportunity and privilege, is another. And then a number of other need-based scholarships like Pell Grants. And then if an individual grew up in an underserved area, these things are all loaded onto a construct which we developed 10 years ago, which is a scale from 0 to 99, with 99 being someone who's faced a lot of economic or educational disadvantage. Someone with a score of 0 is someone who's faced very little. And why do we use this? I think it's because traditional measures, the ones I mentioned earlier, are quite confounded by educational opportunity and privilege and wealth, as I showed. So this numeric scale is really meant to give context to those other measures. So when our admissions committee members look at an application, they're going to see a grade point average, they're going to see an MCAT score, but they're also going to see this scale, Davis scale score. So it's just meant to give context. And what it does do is I think it influences our committee members to look a little bit deeper into that individual's backstory to see whether the context of their education, is such that their grade point average, might have been influenced. Maybe they worked in college, who knows? There's so many things that can influence this. And really, we feel like it's a proxy for an individual's distance traveled, and also for some type of resilience or grit. which is a very important quality of physicians, as you know. The second thing we've done is just as important as the scale, honestly, is that we use, let me go back here. We use we've developed a number of pathway programs. These are within our medical school. So we have 5 of them. 30% of our students are in one of these pathway programs. And each of these programs is designed to develop physicians to serve a particular marginalized community, starting with the rural community of California. That program was established in 2007. So again, someone with a rural background, grew up in a rural area, they come to UC Davis, they have additional curriculum that's aimed towards care of rural populations, and then their clinical training, 3rd year and 4th year, is in rural settings, essentially in Northern California. So we've developed partnerships with various health centers so that they can have clinical experience with that target, if you will, community. Again, we've developed 4 other programs that have other targets. The second one is an urban underserved community. That is patients who receive their care in federally qualified health centers, and then a Central Valley program. Again, people come from the Valley, San Joaquin Valley. We have the 3-year primary care track for about the last 10 years. Again, these are students who have primary care experience in their life. That already, when they apply to medical school, they go through our school in 3 years instead of 4, and they all get they get basically full tuition scholarships. They don't have any debt, and 90% of them go into primary care. And then the last track is one that's relatively recent, established in 2022, is meant to serve Native American and tribal communities of California, of which there are many. About 10% of the American Indian or Alaska Native population, 10% in this country live in California. The students who are in these programs that I just alluded to, the community health tracks, the residencies they choose are quite different from our traditional students. So you can see on the left-hand side of the slide, these are the different pathway programs. The colors represent those different pathways, but about 43% go into adult primary care. That's very strictly defined as family medicine or primary care internal medicine. So that's about 3 times the national rate. But the rest of the students actually go into specialties that are needed in California. I've listed them on the slide there. About 10% go into OBGYN, and some go into general surgery. Again, these are all specialties that are needed in California. I think more importantly than that is that they tend to go into high need areas. So about 50% practice in an underserved area, about 33% practice in a rural area. Again, that's compared to 5% nationally of graduates, and about 90% practice in California. I think I mentioned a couple of these programs. The 3-year ASPC program is funded by the American Medical Association, as well as a grant from Kaiser Permanente of Northern California. It's an organization that I guess feels the primary care shortage. I think all healthcare systems do, but they've decided to invest in helping support students who go through this program. These students tend to be older because they've had primary care experience. The average entering age of a student in this program is 28. About 85% are first gen to college, 70% are from underrepresented groups. They actually start medical school with slightly lower grades and MCATs, but they finish in 3 years instead of 4. And again, 90% of them go into primary care. The middle part of this slide describes a community college to our medical school pathway program. So this is a partnership between a number of local community colleges around Sacramento and then north of Sacramento, that gives students who are in community college some additional, I think, advice, mentoring, coaching that a lot of students from wealthier families and wealthier communities tend to get through their entire lives. We try to give that kind of assistance to community college students in our region, and because community college students, I'll be honest, are much more representative of the United States. So we did a study of primary care residents in the United States. It turns out the ones that do family medicine, a huge percentage of the Latino family medicine residents, 50% actually attended community college, and a third of Black family medicine residents in this country attended community college. So it's a huge source of diverse talent that's probably going to do primary care that we're missing out on because we discriminate against community colleges. And that, community college students are much less likely to be admitted to medical school than people who come from, let's say, the Ivy Leagues. This is just to show you the outcomes. This is UC Davis, the financial distribution of our students, and you can see that it's a much more representative distribution with a greater number of I'll call them average American families. So the US median family income is in that orange bar again. You can see that we have students from across the income spectrum. It's about 60% are at the average or below. So what this means is that I think you have a student body that understands from their lived experience what a lot of our patients go through every day. And I think that's what makes the difference in many ways. So this is a busy slide, and just to illustrate the point that medical education is long. You all know this. It takes a long time to make a physician. It starts, and so in order to change the US physician workforce, you're going to have to start early, and you're going to have to intervene at many points along this pathway, from recruitment and looking at people as they come to college, but looking at them again in a holistic way when they come to medical school, but also residency and again into practice. A couple of things I'd highlight: what you can do as institutions. I think working with pathway programs to try to level what is a very unequal playing field in medicine, and especially the effects of poverty, as I alluded to earlier. There's lots of people in your local community that probably have what it takes to be a physician, and more importantly, have a commitment to actually serving the community in which they grew up. I think we need to build more inclusive learning environments. Some of them I talked about. Some of our pathway programs attempt to do that. And then finally, incorporating community-based training, not in the ivory tower in which we sit in the academic medical center, but rural settings or working at community health centers. That really helps learners that come from those communities to remain connected to the reason that they came to medical school, the patients that they are trying to serve with their careers. What about graduate medical education? I just wanted to talk a little bit about it because I think people have a lot of confusion about the Supreme Court decision with respect to residency. I just put this slide up. The Supreme Court decision basically prohibits what was named affirmative action in medical and higher education admissions. Okay, so that's admissions to college, and we all believe that it applies to admissions to medical school. What it does not apply to is admissions, if you will, to residency. So residency programs are subject to a different set of rules and a different set of legal precedent that has more to do with what we call Title VI, which is employment law. So again, the Supreme Court decision doesn't really apply to residency program selection. Now, in California, we're subject to Proposition 209, but that only applies to public schools. So UC Davis, of course, UCLA, but Proposition 209 doesn't really apply to Stanford, let's say. But just so you know about it, it prohibits consideration of race, color, ethnicity, gender at birth, or national origin in any aspect of our operation. So that means admissions, of course, but it also means residency selection. It also means how we award financial aid, any aspect of hiring. That these are all subject to what is a very strict ban on it's an affirmative action ban. So it's really influenced how we do all of our work here at UC Davis, medical school admissions, residency program, faculty, the whole thing. So kind of my advice that I give to programs that have a commitment to justice, equity, diversity, inclusion is to draw from some of the lessons we've learned and these are ways that I think are legally defensible. Now, again, at Stanford, being a private institution and not being subject to Proposition 209, you may not need to worry about this very much, but I think it's a good idea because there may be more legal constraints coming down the pike, if you will. So developing a mission statement is critical, and using that mission statement to guide your recruitment practices. So if it's community service, then you're going to choose candidates accordingly. A lot of institutions talk about community service. I'm not sure they live it all, and so but so this would be one thing to think about. I think a sense of urgency. I alluded to a burning platform earlier. If there's not a problem you're trying to fix, there's really no need to change anything. And all the work we've done has been to fix a problem. That problem is health disparities in our region. The question, are you producing the workforce needed by your community, by society, is an important question to ask yourself. I would encourage the de-emphasis of metrics and other accomplishments that are influenced or confounded by wealth, opportunity, and privilege. I've listed a few of them there. They have very little predictive value. A USMLE score does predict some things, but it doesn't predict a lot of the things that we've been talking about. Developing tracks within residencies, that is that maybe community medicine tracks. We have a mobile medicine track, and we have a community medicine track where certain subset of residents actually do their clinic in a local community health center rather than at UC Davis. I think that's been a very successful program, actually. And then partnering with 1 or 2 or 3 mission aligned schools that you understand that the students that come from those institutions have the qualities that you're looking for. This was an article published 2 years ago in the Annals of Internal Medicine, which is a call to actually try to look at different measures in the residency and fellowship application process that would address inequities in that process. On the left-hand side of the slide, these are all the variables that are available in the medical school application. I won't go through them, but there are many of the things that we use to kind of develop our distance traveled adversity scale. On the right-hand side of the slide, these are the elements that are present in the residency application. You can see it's not as extensive, and it needs to be. It probably needs to be more granular if you're going to try to do this. In 2023, there was a new section added on impactful experiences, which have to do with whether an applicant's experience hardship in their educational journey that's related to their background, financial community they grew up in, or otherwise. So these are the kinds of things I would try to, try to emphasize in your residency application process if this is something that you want to do. These are some suggestions about mitigating your legal risk. Again, I think at Stanford, you may not have to sort of think about this. A couple things that we do is we make all of our group, programs, outreach events, lunches. They're all inclusive. They don't really call out membership of a particular group or certainly a race. Words matter. Underrepresented in medicine is a term that means that the population, whatever the identity is underrepresented relative to the population. That's better than underrepresented minority, which refers to racial identity. I think program criteria need to be mission-based. That is, again, what are you trying to achieve with your training program? We analyze demographic data, but only once a year after our application season, if you will, is done. That's again to protect us from an assertion that maybe we're looking at race and identity throughout the process. And finally, I would suggest everybody, sort of get to know their lawyer, their institutional lawyer, because there's some legal nuances that I think are important to think about, particularly the tolerance of what I call risk tolerance. Is something like in clinical medicine, we think about risk benefit of the clinical decisions we make. There's a legal framework to do the same thing. That is, I'm not sure you can prevent yourself from legal challenge or getting sued, because right now there are a ton of lawsuits around this issue all over the country. I don't think you can prevent that. But you can lower or mitigate your risk, ideally not just set yourself up for a lawsuit. This is my last slide, which is just to say this is the Shawshank Redemption. It took a long time for Andy to dig himself out of that cell to freedom. So I think this kind of work is similar. It takes a small hammer. It takes a long time to really make a difference in terms of the kinds of big problems we're talking about. Anyway, thanks for your attention, and I'd be happy to take any questions if there are any. Let me stop sharing. Okay, there we go. Okay. Let me see if I can see. There's some in the chat. Let's see, Q&A.
Hi, thank you so much. We are really excited to have this presentation, and I've been learning a lot just listening to different input that you provide. I have Dr. Judy to run the Q&A, but I'm gonna be selfish and ask a question first, if that's
Sure.
okay. You know, it really caught my eyes that you were showing how you have your mission statement and how you focus in really create this next generation of, I would say, community providers, family practitioners, and I wonder how long after you're gonna look at your approach and say, okay, so we have this path away already, and we have this success. Now we're gonna target older specialists. Particular, as you pointed out, the OBGYN is well underrepresented for or ERM. So another specialist, I'm guessing too. So I was wondering about that, what the future
Well,
holds.
yeah, I mean, I think all of if you look at the data I showed about obstetrics and gynecology, the greatest sort of disparity, I'll call it, between the population of California and it is again, it's the Latino disparity. So I think actually OBGYN, if I look at other specialties, there's pretty good representation of some of the other identities, particularly African-American population. But the issue is the Latino population. That's the biggest gap. And of course, in our state, that's the biggest gap among all specialists. So I think if I was going to start somewhere, I'd be there. So, I mean, UC Davis, our school is about 30% Latino every year. Now that's taken a long time to get there. And it's taken a lot of different interventions that I alluded to. I think the other part of your question, Catherine, is how long. It takes a long time. We're just getting attention now, but I've been doing this my 18th year of applying various aspects of what I talked about to our process. And it's been a slow, steady change in the way that our admissions committee works and the way the representation in our school. So I don't know if I answered your question, but I think we're working on it. We need to work on it across all specialties. There's no question about it.
Yeah, no, thank you. I think I was trying to allude a little bit at what you answered. And yeah, no, I think it depends how we apply the data. Now, if we narrow away to our state of California, we know where Latinos are very well underrepresented, having over 40% of your population being, some Hispanic heritage, and have less than 6% of, physicians being Latinos, and less than 2.5% women being Latinos, doctors. So we have a lot of work to do. So it's encouraging to see these approaches. We have few questions in the chat, and I don't want to take it away from Dr. Judy. Amy, did you want to run the chat?
Yeah, I'm happy to. Catherine's or Dakeen's sharing some of them with me because I for some reason can't see all of them. But I have two that I would love to raise. So one is from Christina Oldini. She asks, how many other medical schools in the U.S. are doing similar work or have similar practices?
Yeah, that's a great question. How many other medical schools there? We've been since since that article came out. I mean, I think we've done probably 30. Our team has done probably 30. I'll call them workshops. So that's 30 medical schools where we've shared a bit about our approach. So I think there's a lot of interest. I would say there are between 5 and 10 that use our scale. It's been published. It was published in 2015, actually. So it's a long time ago. So it's, again, there's some uptake, I think, of versions of it across the country. I think it's the Supreme Court decision, right, that is giving people pause. I noticed there was a question about, I'll tell you, the enrollment, we only have 1 year of data since the Supreme Court decision, but already we're doing a qualitative study interviewing medical school admissions deans. We've done about 20 interviews so far. I would say in almost every school, every public school, the enrollment of underrepresented groups has fallen in this first year. So it's going to happen. So anyway, I do think there's a lot of interest. I'll say it that way, Dr. Amy.
Certainly a hot topic. The next question I see is, what metrics do you use to know that this approach improves health outcomes?
Yeah, I mean, that's the long game. I think you have to begin to, so so we have our own data that the metric that we can show that our graduates are more likely to work in rural communities. They're more likely to work in health profession shortage areas. I mean, that's to me a very real outcome, because there's other data again that suggests the presence of a primary care physician in any community in this country is going to improve health outcomes. But I mean, we're looking at those, they're long-term outcomes. And it takes, that's why I think people don't do this work. They're just thinking about next year, 2 years, 3 years. This is not that kind of work. But however, I will tell you, the health disparities, you have the Latino health disparities, they're very entrenched. They're stark. So, you know, I think we should do something about that. And certainly if you're a school that's committed to health equity. So.
Thank you. I have another question here from Dr. Ron Gibbs. Yeah, he says, thanks so much. Has there been an increase in medical student diversity in the last 2 years? My medical alma mater back east released data in 2024 entering class, which showed a priority on diversity.
Yeah, that it's hard to know. Again, we really only have 1 year of data, and it's not been really released. So I only have anecdotal data to be able to answer that question. I will say I have anecdotal data that in certain private institutions, so again, like a Stanford, that some schools have been able to increase the representation. I don't know which school, anyway, we don't have to name names, but I wouldn't be surprised, again, if you're focused on a mission state, if you're a mission-driven school, and I think you've built your system to achieve your, that outcome, I think you can achieve this. There is a school back, I'll just name names, the University of Massachusetts in Worcester has actually increased its representation by a number of interventions that have to do with a focus on mission, what they're trying to achieve. It's not diversity. That's not the mission. It has to do with health equity. And I think, but if you look at the economic disparities, I'm not sure anybody thinks it's right that low income kids can't get into medical school. I mean, I think people think it's wrong. So, I mean, I think you have to do something about that. But anyway, so to answer the question, yes, there are some schools, but I think it's a small number.
Thank you. Dakeen, are there any additional questions you can see in the chat that I'm not able to see? Those were the two that I can see.
Yeah, there's no
Or in
more.
the Q&A, I'm sorry. I think I
There's
lost some of them. when
no,
I-
there was just two. It's because you and
Okay.
then in chat, let's see. So Kate has her hand raised.
Oh, great.
I can make her speak.
Unmute her. Yeah.
Yeah.
Can't see.
Okay.
I can't hear anything. Is someone?
Kate, I've allowed you to speak. There we go.
Hi, can you hear me?
Yeah.
Yes, yes.
Thank you so much for this presentation and for all the work. I'm wondering about people's missions, right? So when we've had this focus on diversity, equity, inclusion, which is really about health equity, how have people changed their stated missions, or how have they changed that kind of perspective or outlook as the Supreme Court's decision came down? Was that a strategy people started to think about changing their focus?
I mean, I think for us, Kate, the mission statement, I mean, the mission of health equity, that's been something that's from the beginning for us. Again, we started this 15, 16 years ago. So I think that health equity is certainly not prohibited by the Supreme Court decision. Again, the Supreme Court decision has to do with, admissions to higher education, and that there should not be consideration of race and ethnicity in that process. So health equity is protected. I mean, not protected, it's not illegal. I think so I think people have changed their mission statements, but it's not about the statement, as you know this, it's about the actions. I think a lot of mission statements have health equity adjacent principles in them. The question is whether or not the institution actually acts accordingly, meaning do their practices follow that mission? And that to me is where the work is. So if you're running a program, you're a residency program director, or you're in charge of something, I think you have to appeal to that mission statement, and try to, again, take action on that mission statement. That's really where the difference is. I find schools are now taking it more seriously, perhaps, than they did before. I think that lots of national organizations, the AAMC, which is the Association of American Medical Colleges, has prioritized health equity as it's a common good, it's a social good, and realize that medical residency training is mostly funded by taxpayer money. It's the Medicare Trust Fund that gives $22 billion a year to pay salaries for residents in this country, most of them.
Thank you. That's great. I think health equity is the heart of it and the reason we do it. I just think the statements on websites where people feel at risk are ones that focus on diversity, equity, inclusion. So I was just wondering how you've seen
I think that's right. Yeah, some of that last slide I showed about sort of mitigating your legal risk. I think that kind of language probably needs to be modified. But I would suggest consulting with whoever the legal counsel at your institution, and believe me, they're thinking about it, I'm sure. And I think that because I think actually it's helped me to understand what's okay language and what's not, and I think none of us are lawyers, so I think it's hard to know. But yes, I definitely think some of that language needs to change, particularly events, outreach events. You're having a lunch for this particular interest group. There are a lot of things but for us, again, we've been prohibited from doing this for 25 years. So like at UC Davis, we don't really label stuff like that anyway. But I think it might be a good idea to review that stuff. Remember, the Supreme Court decision doesn't apply to anything but admissions to college. Actually, it's actually college, like I said, but most people think it applies to medical school admissions, but not GME admissions, not faculty, at this point, at least.
Thank you, Dr. Henderson. It's such an interesting perspective. I think following the 2023 Supreme Court decision, as residency programs, we were given basically guidance to revise our practices much more in alignment with sort of what you're describing as what you guys have done so wonderfully at UC Davis for a long time. But it's interesting, it seems like a lot of varying interpretation around this. Has that been your experience?
Oh, absolutely. I mean, wow, Amy, I think to me that you're hitting the important point. If I'm a program director, I would advise not just listening blindly to your lawyer, but having a conversation with them, because they, like physicians, have a certain risk tolerance. And I think that's the question. It's not because some lawyers, they want you to do everything you can to never get sued. I'll tell you right now, I don't think that's even possible. All you're trying to do is mitigate the risk of being sued. But I think in your instance, if they're probably going overboard, that's my opinion. But all I would suggest is that you have a conversation, say, well, really, like, tell me how or why, and try to I've had to educate myself about this. And even, we've been doing this for 25 years. I'm not under the illusion that we're not going to get sued. I'm not trying to, I think we probably will, but remember, there are a lot of frivolous lawsuits out there. Are you kidding? They happen all the time. So I think that you have to decide what you want. And I think maybe push back a little bit, because especially an institution like Stanford, you're not, again, it's admissions. And you're not subject to Prop 209, which is this other thing. So, and I'll just tell you, Proposition 209 is a lot more restrictive than the Supreme Court decision. So go back to your mission. I'd say that if it conflicts with the advice, then say, well, aren't we, what about that mission statement? I don't know. Try to light some fires. Yeah, you're gonna have to light a fire. There has to be a fire. Why would you do anything differently if there's not a fire? But I think so. To me, as a leader, I was a residency program director for 15 years. all I did, not all I did, one of the things I did was to light fires under the leaders at my place.
Such important work. Thank you so much. I don't see any additional questions. Dakeen, can you double check that for me that we've gotten everything that showed up in the chat in the Q&A, because that's the part that I think I lost some of.
Yeah, yes,
Yeah.
we're good.
Awesome.
Well,
Thank you so much, Dr. Henderson. This
Yeah.
has been such important work to review.
Yeah,
We
thank
appreciate
you
you
so
all.
much.
Have a great morning. Okay.
you as well.
Bye.
Thanks.